Thank you so much, Chad, and thank you, everybody. I heard the applause. It's great to be here virtually today. I'm really excited for this opportunity to share with you on a topic that I think you'll be able to see I'm very passionate about, but not just that. I think this is a topic that is fundamental to our understanding of delivering high-value, patient-centered, empathetic care. Um, this topic is really about the ways in which psychosocial trauma, so not physical trauma, but psychosocial trauma and adversity can show up in various forms in a multitude of consequences. But the thing is, trauma is something that we are incredibly good at hiding. And so some people have called this issue of trauma and the way it affects health as the hidden pandemic. So there's a saying that before this pandemic that we're currently experiencing, there was already a pandemic that was already conferring significant health problems on a population level. Now, this is a topic that I did not learn in medical school. In fact, I was 3 months away from graduating my residency. I went to Rush for Med Peds. I was 3 months away from graduating when I serendipitously attended a grand rounds kind of like this. And as the speaker was sharing, my jaw was just on the floor for so many reasons, which we're going to unpack in the next 45 minutes or so. But one thing that stuck out to me and sort of represents the initial elephant in the room, and the thing that kind of got me into this topic is how we can so easily misunderstand a patient or a family member because we lack context, we lack narrative context. And so to illustrate this, let me share about a personal story. A couple years ago, when my wife, who was then pregnant with our second child and went into labor, we checked into a local hospital in Atlanta in the evening. Within a few hours, my wife had gotten her epidural and was feeling great. We had some music on, got some food, and we were just kind of hanging out until baby was ready to come out. But a few hours later, the epidural wore off, and it was my job to get the attention of a nurse to help come, redose the epidural. Long story short, it was a really busy night in L&D, and some hours went by before someone came in. And in the interim, my wife's pain continued to increase, and it got to a level where I had never seen anybody really in so much pain before. It was unbearable. She could hardly sit still in the bed. And while we were waiting, I took off her blood pressure cuff that was pushing on the PIV. It was cycling every 5 minutes. And in our frustration, I was like, we don't need this. You're not at risk for preeclampsia. You're not hypotensive. So I'm going to do what I probably shouldn't do and just take this cuff off. And then 5 minutes later, someone from the anesthesia team comes in. And the first thing this person says is, as my wife is crying in pain, the first thing they say is, what is that blood pressure cuff doing on the bed? It needs to be on her arm at all times. And he kind of, huffs and puffs a little bit and walks over to the bedside to put it back on. And in that moment, which was somewhere between 4 and 5 in the morning, I lost it. I just completely lost my temper. And when that happens, for some reason, I get really sarcastic. And so I started saying, are you seriously asking about the blood pressure cuff? Is this really the first thing you want to say when my wife has been waiting in pain for 2-3 hours now? And this person actually shouts back at me. And for the next 30 seconds, we go back and forth while my wife is just laying there like writhing in pain. And eventually he brings back, he says, okay, I'll be right back. He go gets the next, he gets the medicines for the epidural, redoses her. And within a few minutes, my wife is feeling better, which makes me feel better. And then I turn to him after I've kind of calmed down a bit I say, wow, like I'm really sorry for losing it there. And he actually apologizes back to me. And a few hours later, our daughter is born without complications. But I still remember how I felt. And this was, one night 2 years ago. And I share this story because I would never want to be defined or known by a moment of anger, of frustration, a moment of exasperation, especially if it's in the context of a very stressful situation. And no one wants to be known by their worst moments like that. And yet, in the rapid pace of our health system, patients and their family members are often labeled all the time for what we the umbrella term challenging behavior. And to me, this is one of the biggest elephants in the room in the way we practice medicine. Because whether it's one of those like FYI flags that are in the EPIC chart that states, this person is a seeker of pain medicines, or some note that states how this person was rude or agitated to a physician or nurse, 10 years ago, those labels hardly ever include the underlying context out of which an undesired behavior occurs. And if you don't believe me, just think about what goes through your mind when you see the terms left AMA or self-DC'd metformin or endorses 10 out of 10 pain, but they're texting on their phone, right? What thoughts immediately go through our head when we see those words? And so that's what this talk is going to address today. It's sort of the scientific rationale for empathy and how understanding this rationale can really be useful for us and be another frame by which we can maintain a holistic and compassionate perspective of our patients. And so ultimately what we're going for is better health outcomes with this. So I have three main topics that I'd like to cover today. First, what are we talking about between trauma or adversity and these health outcomes? What does the data say? Secondly, how does trauma show up in the hospital or the clinic? How does it show up in the patients that we treat every day? And third, what do we do with this knowledge? How should this information inform the way we practice? What are some pragmatic suggestions and tips that we can use going forward? So I kind of broke this talk up into three elephants. And so elephant one is the first elephant that I want to call attention to is this association, this connection between trauma and health. This might be something that some of us might not even realize is an elephant, but it is. We intuitively know, right, that the most common conditions that we treat in internal medicine, high blood pressure, diabetes, hyperlipidemia, stroke, heart disease, it's the most common conditions that we see in the clinic. We know that they didn't develop yesterday, but we really don't have a great way to integrate this sort of life course perspective into our care. And I think we should. Why? Well, let me start off by telling you a story that kind of sets the stage for why this whole topic is somewhat of a paradigm shift. So if you can come back with me to the mid 1980s, we're in San Diego, California. And at the time, there was a physician named Vince Felitti, and he was in charge of overseeing a weight loss clinic, excuse me, that was actually really successful. And so men and women would come in, they would lose weight, and they would actually be able to keep it off as long as they were sort of continued to be participating in the program. But over a period of 5 years, he picked up on a troubling trend. Despite the program being really successful, very effective, helping people lose weight, keep it off, many people were just suddenly abruptly leaving the program. And what confounded him even more was that most of the people who left were actually at their goal weight, or they were losing weight when they left the program. So the question is, why would people leave a program if it was doing what it was designed to do? So being the very curious person that he is, Dr. Felitti decided he would try to interview as many of these people who left the program as he could find. And it actually just happened through one woman's story where he stumbled upon something completely unexpected. And so he interviewed about 280 participants. And from this one woman's story, what he learned was that when she came into the program, she was over 400 pounds. And through her progress in the program, got down to about 130. And then one day disappeared. And several weeks later, she comes back having regained almost 40 pounds. And so when she was interviewed, she shared that a coworker, after she hit this weight of around 130, one day a coworker, an older gentleman, made a sexual proposition to her. He hit on her. And this unexpected, undesired solicitation triggered these deeply buried memories of her own grandfather repeatedly sexually abusing her when she was in her childhood years. And it was during this period of abuse that she began this pattern of binge eating. And what she noticed was that as she gained weight from binge eating, she became less and less noticed by her grandfather. And she sort of unconsciously or subconsciously extrapolated or generalized that strategy to other potential predators as she grew up. And so for this woman, binge eating and gaining weight was actually her way of protecting herself and going unnoticed from other potential predators. So Dr. Felitti, stunned by this, he went back to his team. He said, we got to ask everybody about what their lives were like in childhood, because it could be a reason for why they left the program. And so they went on to find in this small study, this case control study of about 300 people, that almost 60% of people had a history of abuse, and that sexual abuse was particularly common. And so the key lesson for Dr. Felitti and his team, what sort of allowed them to see the forest for the trees, or what was kind of the aha moment for them, was that what they saw or perceived to be the problem, in this case, obesity, was in fact the solution for his patients, but a solution to a problem that was not obesity, but a different problem that happened decades earlier. Their solution was actually a defense mechanism or a maladaptive survival skill, but of course, one that had very severe and significant health consequences. And so these findings, led him to ask the question, well, what other experiences that we endure or encounter in childhood can actually inform our health behaviors and health in the future when we're adults? And so these questions were brought together in what we call the Adverse Childhood Experiences Study. We call it the ACE study for short. This is it's considered a landmark publication in the public health world and in the field of trauma research. It's been cited over 12,000 times, and yet we don't talk about it early enough in medicine, and we certainly don't talk about it at a broad level in medical schools. And so people are often surprised to learn that this study was published in 1998, over 20 years ago. It is not a new study. And I wouldn't be surprised, if over half our audience here today had never heard of the study before. Even in pediatrics, there's not a great familiarity with this study. But to make a long story short, this was a monumental and joint effort by the CDC and Kaiser Permanente in San Diego. And what these researchers did was they surveyed over 17,000 adults on their history of childhood trauma or adversity, or again, what we call ACEs for short. Now, these ACEs spanned 10 categories across 3 domains of abuse, neglect, and household stress. And so within abuse, they asked about physical, emotional, or sexual abuse. Within neglect, they asked about physical or emotional neglect. And then they asked about 5 different types of stressors that a person could grow up experiencing in the home. Things like mental health problems or substance use disorders in a family member, an incarcerated relative, intimate partner violence against the mother, and then lastly, parental separation and divorce. Now, with these data, the ACE study was actually an ACE study series. And so after they had this sort of captive audience of 17,000 adults, all recruited through Kaiser, they were actually able to follow these patients forward for about 10 years. And so it actually became a cohort study that was longitudinal and led to the publication of about 90 papers in total. Now, I'm going to condense all those findings into 3 key findings for the sake of simplicity. And the first one is what you see here, that ACEs were incredibly common. Prior to this study, there was this sense that in society, that problems in the home, problems in the household were synonymous with problems of the poor. But one thing the ACE study clarified from the start was that no, actually trauma is universal. It's a lot more common than we might realize. How common is it? Well, when they quantified the number of ACEs each person had, they found that 2 out of every 3rd person, 64%, had at least 1 or more ACEs. So that would be, almost 2 out of every 3rd person here. On the flip side, only about 1/3 or 36% had a childhood that was free of any of these events. So the first key finding is that ACEs are common. The second key finding is that researchers, they observed that ACEs can profoundly impact our health and well-being in a negative way across multiple domains. And so what they found was the higher number of ACEs a person reported, the higher risk that person would be for some of the most common health and behavioral problems we see in the US. Things like substance use disorders, like smoking cigarettes, heavy drinking, illicit substance use, mental health problems like depression, anxiety, history of a suicide attempt, even PTSD. They found that ACEs are associated with chronic disease. So this is what had my jaw on the ground, the idea that things that happen in childhood could actually show up in the form of chronic disease decades later. And we're talking about things like COPD, type 2 diabetes, non-skin types of cancer, adult onset or ischemic heart disease, even stroke and obesity have been implicated as well. And then they found that ACEs aren't just related to health, but they actually inform and influence some of the more socially facing, socially important outcomes like the ability to hold down a job, maintain a job, and maintain financial stability. Excuse me. And then lastly, they found that ACEs are strongly associated with problems all throughout the school years. And so ACEs do not skip over the pediatric years. For purposes of this talk, I'm focusing mostly on the adult related outcomes, but make no mistake, ACEs do not skip over the childhood years, and we have a lot of data on that as well. Just to give you an example of what this dose response relationship looks like graphically, this bar graph shows a number of different mental health outcomes, the prevalence of a number of different mental health outcomes, not risk, but prevalence, with the corresponding ACE score in the different colored bars. And so what you can appreciate is that there's a stepwise gradient of the prevalence of these outcomes according to the ACE score. So essentially, the higher the ACE score, the more prevalent these conditions. The same thing, we see the sort of the same staircase or dose response pattern with really ACEs and all the outcomes that I've already mentioned. But here we're looking at impaired worker performance. So some of those more, again, socially important outcomes like job absenteeism, having financial problems in general, and then having job problems in general as well. In terms of risk of specific outcomes associated with ACEs, we know that there's a wide range of important observations here. So for people with 4 ACEs or more, compared to those with no ACEs, after you adjust for age, sex, gender, race, ethnicity, and educational attainment, which is a proxy for socioeconomic status, the risk of some of these health risk behaviors is quite substantial. And so for a history of suicide attempt, the odds are 12 times greater for people with 4 ACEs or more. For IV drug use and alcohol use disorder, between 7 and 10 times greater. So these are very high, very strong associations with large magnitudes of association. For chronic diseases, some of the most common conditions we treat in internal medicine, the risk is high as well. And so again, if we compare those with 4 ACEs or more to those with none, the odds for having a history of COPD is almost 4 times greater. For stroke and heart disease, over 2 times greater. For any cancer or diabetes, over 1.5 times greater. And I will say that these are data from the original ACE study, but since then, many population level studies with hundreds of thousands of participants have essentially shown the same sort of dose response relationship between ACEs and these chronic diseases shown here. In my own research, being a person who's med-peds trained, I was interested in the question, well, do ACEs increase the risk of earlier onset chronic disease, specifically among young adults? And so in this analysis that included over 100,000 participants, we found that yes, although the absolute prevalence of chronic conditions is certainly lower among younger adults, ACEs are nonetheless significantly associated with earlier onset chronic disease. So not only is trauma already bad in itself, right? The experience of trauma itself is negative, but not only is it associated with a multitude of health outcomes, but now it also increases the risk of accruing or developing these conditions at an earlier age. And so this is the big deal. Why? Because it makes a big difference if someone is diagnosed with diabetes at 32 versus 75. That's a lifetime difference of financial burden, adverse effects from medications, complications from the disease, et cetera. And so trauma really is a root cause in part of a multitude of sort of morbidity at large on a population level. Now, the final key finding from the ACE study series really follows the logic from the first two. And so if ACEs are common and they are associated with a multitude of negative health outcomes, at some point, we should expect to see, if we're looking forward or following people forward, we should start to see an impact on mortality. And I think this is the most stunning finding of the ACE study series. When the ACE researchers followed these 17,000 participants forward for about 10 years again, they saw that for those who had no ACEs, the average lifespan was 80 years. But for those who had 6 or more ACEs, the average lifespan went from 80 to 60, a difference of 20 years. Again, the measurable difference between these two groups being the burden of trauma that was experienced before the age of 18. Just let that sink in for a second. To me, it's just a stunning statistic every time I see it. Now, while the original ACE study only included ACEs that occur in the home, right? We kind of refer to those as like the interpersonal ACEs of abuse and neglect and then household stress. We also have to acknowledge that there are many more types of trauma that are important and influence health trajectories. So one way that we like to conceptualize this is with this illustration, which we call the tree of ACEs. And so if you imagine with me that the leaves and the branches of this tree represent the conventional or interpersonal ACEs, abuse, neglect, and household stress. Well, as a tree is growing, it's growing out of a network of roots that provide the foundation for that tree. And we refer to the roots as adverse community environments. These are things like violence in the community, poverty, joblessness, racism and discrimination, unaffordable or unstable housing. In and of themselves, each of these are independently linked with poor health outcomes. But as they pertain to the ACEs, right, the leaves and the branches, these adverse community environments are thought to provide a sort of contextual pressure out of which those leaves and branches might occur at higher frequency, higher severity, or in the absence of a helpful or mitigating resource. And so one example that I encounter all the time, I encountered it actually just today in my peds clinic, is that poverty is like pouring gasoline on the fire of ACEs. Poverty undercuts the resources available dramatically, even for people who really want to pursue help. So I had a mother in clinic today of a 4-year-old who clearly had some mental health issues going on, and she wanted resources, she wanted counseling for it, but she was not insured. And so now we have to weigh the risk and benefit of having a huge financial burden put on her shoulders for her to get mental health counseling. And that's just not a very just system. I don't want to digress too much, but that's just a problem that should not exist. Now, this illustration doesn't stop here with the roots. So as a tree is growing, it is pulling in minerals and nutrients from the surrounding soil. So in a lot of ways, what's in the soil can sort of predict that the tree's future trajectory. So we refer to the soil as adverse collective historical events. These are things, I put examples in recent history, whether it's slavery, Jim Crow, mass incarceration, the Holocaust, genocide in Syria, forced displacement of Native Americans, and of course now COVID. But these are all events that have conferred an intergenerational impact. And what I'll say very quickly about this is that if you've been following the field of epigenetics in the last 10 to 20 years, there have been some stunning findings from this body of research that suggest that trauma can actually be inherited across generations, and we can measure this through changes in the epigenome. Now, so if we take a step back and we think about what we just covered, right? I hope what becomes clear is that the experience of trauma for a lot of people is not just an experience or just a part of someone's past, right? On the contrary, actually, the experience of trauma can be devastating across so many domains of well-being and functioning in our society. So at this point, you might be asking, all right, Stan, like all this trauma has already happened in my adult patients. So what do I do with this information? And I would argue that knowing this association exists still has substantial implications on our practice. So let's move to another implication of trauma in our clinical encounters. So this is the second elephant in the room. It's this, and what we're going to do here is unpack this dynamic between psychosocial trauma and behavior and how this shows up in clinical settings. To give some perspective or framing for this section, what's important to understand here is that in children, right, we're talking specifically about children, the most common manifestation of ACEs, of trauma, is actually in behavioral problems and maladaptive coping tendencies. So this is a list here. It's not exhaustive, but it's a list of some of the most common outcomes associated with ACEs in children. And what you'll notice is that most of them are related in some way to a child's behavior. So it's no surprise that things like academic failure or delinquency would be among the top social outcomes. Just because a teenager turns 18, it would be a mistake to think that all of these behavioral problems would suddenly vanish or just resolve on their own, right? So really what we're asking with this question of like, how does trauma show up in the clinical encounter? To get to that answer, we have to answer this question first of like, how is this happening? Like, what is driving this relationship between ACEs and these health outcomes? In the past 2 to 3 decades, with the advent of more sophisticated brain imaging modalities, there's actually been this remarkable convergence of research from multiple fields: child development, psychology, neuroscience, medicine, even cardiovascular epidemiology. And what sort of entity or construct these fields have been converging on is understanding how stress and trauma really disrupt our brain's physiology. We've known for a long time that healthy brain development is fundamentally experience dependent. Let me say that again. Healthy brain development is fundamentally experience dependent. That means, in the first 2 years of life, there is a dramatic proliferation of the neuronal network within the brain, followed by a period of pruning thereafter. And one phrase that's really important is neurons that fire together will wire together. On the flip side, neurons that do not fire together that often will have, and perhaps as a result of not having that experience-dependent input, they're not going to wire together as readily. And we know this to be occurring based on studies that have evaluated early child developmental outcomes like vocabulary and language development. So this figure on the right is from an older, also a landmark study that was done in the 90s. That's why this term welfare here is there as a label. What it shows is the different number of words children know according to their parents' socioeconomic status. And so what we can appreciate is that by 3 years of life, or 36 months, there are marked differences in the number of words children know. And as early as 18 months, we can start to see these disparities emerge. And the difference of words that children know, of course, is based on their parents' socioeconomic status. What's happening here? Well, the hint is it's not that anybody who's not a college-educated parent doesn't love their children. That's absolutely false. The answer here is the adverse community environment of poverty. So what is it about poverty and these other adverse community environments? What is it about ACEs that can promote disparities in language development? Well, conceptually, and I'm really simplifying here, but conceptually what's happening is that ACEs and these adverse community environments like poverty, they can provoke this severe stress response mechanism called toxic stress. Toxic stress is not the same as like a bad day, okay? Toxic stress is, it's not, we'll get to the definition in a second, but it's kind of like it's a hijacked stress response system. It's a stress response system that's dysregulated, has a hard time shutting off, even when the threat that is perceived may not be an actual, real, and present threat. If toxic stress is experienced during childhood, which is a very sensitive period for growth, it can profoundly disrupt normal brain development, which we'll talk about in a second. Now, another major consequence of toxic stress is that it stimulates this sort of dysregulated activity of the amygdala. The amygdala in our brain is the part of our brain that functions as kind of the headquarters for managing stress and threat. And among many roles, it has it plays a significant role in activating our sympathetic nervous system and also regulating our HPA axis. So with persistent activation of the amygdala through repeated perceived threats such as trauma or adversity, it will lead to dysregulation. It can lead to dysregulation of our neuroendocrine and our immune systems, which can then lead to cascades of chronic inflammation, cytokine release, which we know is a precursor of chronic disease. Let me talk about or share about one, I think it's a fascinating study that was done out of Boston. It was published in Lancet a couple of years ago. And this study really highlights this relationship between stress, the role of the brain, the amygdala, inflammation, and disease. And so what this group did was they took about 300 patients and they all underwent whole body PET CT, and they used validated, existing methods to assess the activity level of the amygdala. And then they kept track of which patients developed cardiovascular disease, like a heart attack, angina, or stroke. And what they found was that higher amygdala activity, which is shown here on the right column, higher amygdala activity actually predicted incident cardiovascular events. And this process seemed to be mediated by two other signals of inflammation: increased hematopoiesis in the bone marrow. Here we're looking at bone marrow within the spine, as well as arterial inflammation, which you can see here in the proximal or the ascending aorta. And so the mechanism they propose, I would say compellingly, is that in response to chronic stress, the amygdala initiates this cascade of pro-inflammatory events that substantially increase the risk of undesired or adverse cardiovascular events. And when they, excuse me, when they assess the risk of a cardiovascular event from high amygdala activity, in which, again, they defined as amygdala activity that was above the 90th percentile, even after they adjusted for common covariates of heart disease, age, sex, Framingham risk score, other cardiovascular risk factors like smoking, high blood pressure, diabetes, a family history of cardiovascular disease, even after they adjusted for pre-existing cardiovascular disease, the association held. And so there appears to be some kind of independent effect that stress and adversity has on inflammation and developing heart disease. Now, one thing I'd like to highlight too is how the effect of chronic stress on the brain, how stress on the brain can actually influence regions of the brain that are really important for mediating behavior. These are regions of the brain that are really important for navigating the world. And so, and I'm also sharing this, my caveat is it's a very simplistic illustration, non-comprehensive, but the general idea is that, again, as toxic stress promotes overactivity of the amygdala, there's evidence that shows inhibition of areas adjacent to and within the prefrontal cortex. So essentially, when the amygdala is persistently activated, there are moments in which the prefrontal cortex's activity is downregulated. We know that the prefrontal cortex is the most complex part of our brains. It's responsible for many executive level functions like planning for the future, having self-control, empathy, reasoning, controlling impulsive behavior, even like accessing working memory. And so the key here is that when the amygdala is activated, the prefrontal cortex is not in control, or it's partially offline. And this of course has real life implications on behavior. When a person feels like they're in threat, that means the amygdala is in charge, the prefrontal cortex, not so much. And so in the clinical context, what might you see? Well, what might we see, right? First, before I get into that, I think it's important to remember that perhaps even despite our best intentions, many patients do not find hospitals, health centers, or clinics to actually represent a place of healing. In fact, it's not unusual to feel that the clinic or the hospital is a dangerous place for a lot of our patients. And so I think it's important we realize that just the very fact of being at a hospital can put a person, make them on edge. Now, this is a non-exhaustive list of 3 sort of common behavioral outputs we might see when a person is activated, when some threat, real or perceived, triggers activity of the amygdala. So hypervigilance and hyperarousal. This is a heightened sense of a perceived threat or danger. This can show up as an intense affect, as anxiety or excessive worry that might seem out of proportion to the issue at hand. Hypervigilance can make pain management really, really hard if the patient perceives that any change to the regimen is going to result in a bad outcome. The second one that we see, the behavioral output we see often, is emotional dysregulation. This is the ability, or inability rather, to regulate one's affect under stressful conditions, even mild stressors, right? This can be occurring in that patient who is yelling in the hallway because they've been waiting on the doctor for a long time. Or this is a true story. This could be the patient who refuses transport to dialysis because they didn't receive a certain type of requested food on their breakfast meal tray, right? So emotional dysregulation is a very common output of toxic stress. And avoidance is another common one as well. So this is avoidance of thoughts, memories, sensations, even conversations that remind people of past experiences. This is a really, really common maladaptive coping strategy that often leads to a substance use disorder. I'll say that I have yet to meet a person with alcohol use disorder who was not trying to run from some type of pain. So that's the long and short of the second elephant in the room. Now, the third elephant in the room, so just to recap, the two elephants that we talked about first were first the association between trauma and health outcomes. The second one we talked about was this connection between trauma and behavior. The third elephant is also a very, very important one to discuss. And this is actually the relationship between trauma and ourselves. And so what we're going to do next is talk about how trauma shows up in our day-to-day. And what I've done is I've combined this part of the talk with a final section on what we can do, since it just kind of naturally flows that way. If we go back a second to the ACE study, the original ACE study that was published in 1998 that I discussed earlier, as it turns out, the people who were included in the study were not a group that the media would portray as at risk for childhood adversity or trauma. I mean, these 17,000 adults were mostly white, they were mostly college educated, and 100% were insured. So based on sociodemographics, this sample perhaps more closely resembles an educated academic medical audience, perhaps more than our own patients. So one thing we have to realize right away is that the experience of childhood adversity is much more widespread and common than we might realize. We have trauma too. And so we would be remiss not to draw the same connection between ACEs and our own health and behavioral tendencies, especially this year, right, with COVID. So some things that we have to be mindful of: secondary trauma, that the negative changes over time experienced by healthcare personnel and staff as they witness seemingly endless suffering and need. Over time, this can lead to changes in our well-being, psychological, physical, even spiritual. We have ACEs too. As we just saw on the previous slide, we certainly have our own trauma. And perhaps most importantly on this slide is the fact that our threshold to act out of, our threshold to deliver care, the care we want to give, can really be, let me rephrase it. Our threshold to act out of our stress can be lowered by context. So when we're hungry or tired or fatigued, these higher level cognitive processes are so much harder to execute well. So what happens when we get stressed, right? What are the behavioral outputs that occur in us? It's actually just the same things that we just described for our patients: hypervigilance, emotional dysregulation, and avoidant behavior. We can fall into the same things. But here's the thing, right? And this is kind of the last big section here. We know that not everybody who's experienced trauma in childhood is going to be doomed to these consequences. I mean, we all know people in our lives, it might even be you attending this conference, who have made it against the odds. So what is it about people who are able to live a healthy, adjusted life despite having high numbers of ACEs? The operative word that we like to mention is resilience. This is defined in trauma circles as the ability to adapt and succeed in the face of adversity, or when someone bounces back after a stressful event, or when they bend but they don't break, as illustrated with the tree on this slide. There's two things we have to know about resilience. First, it is not something that people are just born with, that they have from day one of their life. Rather, it is built. Resilience is cultivated and built through the type and the quality and the number of positive adult relationship that a child has, the social ecology, if you will. It can also be strengthened or reinforced in adulthood as well. And the second thing we have to know about resilience is that when it's present, That means even in the face of future ACEs or future trauma, that person has a higher likelihood of adapting and succeeding compared to another who doesn't have that sense of resilience. So what are the critical factors for cultivating resilience in children and also in adults, I would say? The first one, this is the game changer, is the irreplaceable nature of healthy relationships. It's not a medication. It's not a program, an app. It's just the unsexy grind of a committed, safe, stable, nurturing relationship. So much of trauma is represented by failed or broken relationships. The way we both promote resilience and heal from trauma is actually through, again, these sort of healthy relational models. And in children, this is an absolute game changer, but it's also very critical among adults as well, because whereas adversity makes us vulnerable, healthy relationships protect us. The second critical factor is to cultivate practices and rhythms that can foster self-regulation. And what these activities do is they calm the activity of the amygdala, they help to open up the prefrontal cortex, and they kind of help the brain to coach itself to realize, hey, like that threat you think is that's coming at you, actually it's not a real threat at all. Then that threat's not gonna hurt you. And we actually already do self-regulatory practices in society in a lot of ways, whether it's through prayer, exercise, yoga, deep breathing, journaling, creating art, making music. There's so many ways, but there are also some very intentional ways to cultivate these regulation skills, such as mindfulness, that can help the brain, again, that can help the brain to realize, actually, you know what, there's no threat here. So again, resilience can transform what could become toxic stress into tolerable stress. And bottom line, ACEs are a risk factor for negative health and behavioral outcomes, far from a guarantee. And so if this is true, right, then what should our approach be for patients who have experienced who might have experienced, we don't know, right? We're really good at hiding trauma. So what should our approach be for people who might have experienced trauma in their childhood? And this is where this idea of trauma-informed care comes into view. It's when it makes sense. When we talk about care that is trauma-informed, we're talking about a framework, not a checklist, not a simple list of things to do, but a framework. And this is a framework that is grounded in understanding what trauma is, how it affects us, and what we do in response to that. And the first, critical pivot, mental pivot that we have to make to be trauma-informed, and if there's anything that you remember from this talk, I hope it's this slide. And it's that whenever we see a patient or a friend or a family member or a colleague that's exhibiting behavior that we might label as problematic or self-destructive or counterintuitive. And one example that always comes to mind for me is a woman in her 40s who I've admitted multiple times here at the Safety Net Hospital where I work. She has a history of end-stage liver disease and chronic pancreatitis from alcohol use disorder. I've admitted her multiple times because she continues to drink. And so when we encounter these situations and we have that thought of like, you wouldn't be admitted if you just stopped drinking, or why can't you just, or don't you care about your body? I mean, we all, if we're honest, we all have those thoughts. What trauma-informed care is asking us to do is to pause. And instead of thinking and going along with that thought train of what's wrong with you, like why can't you just, etc., what we're asked to do is reframe the approach as what's happened. Because here's the logic chain. If trauma is common, like we've established, if it's associated with all of these mental health and physical and social health problems, which we've established, and if what we might perceive to be the problem might be that person's solution or survival skill, then saying what's wrong with you, and I'm not talking about literally saying what's wrong with you, but saying it, whether it's the brevity of the encounter, how much time we spend on that person's chart, what sort of opinions about them we have after we leave. So saying what's wrong with you is the wrong thing to say, and that could actually further marginalize a person who never asked for that trauma in the first place. And so as it turns out, this patient that I mentioned earlier, she had a substantial history of trauma, specifically abuse, sexual abuse when she was a teenager. It was never known by any health provider or caregiver. She kept it to herself. And so it had never been addressed. And so to deal with the emotional and mental consequences of that trauma, she found her solution through drinking. If she drank in the morning, she could go to work and pay the bills and keep a roof over her children's head and food on the table. And of course, this ultimately caught up with her and was showing up now. But I hope what comes across is this sense of, if I had come at her with what's a typical "what's wrong with you" approach, she may never have disclosed the history that she shared with me, which ultimately allowed me to better understand her situation more and get her plugged in with resources in the community. There are 4 things that trauma-informed clinicians can do. And this is more of like a process-related slide, but these include realize, recognize, respond, and avoid re-traumatization. Realizing trauma is simply what we're doing now. We're talking about it. We're establishing this connection between trauma and health. Recognize, I think, is the hardest thing to do, and it's a rate-limiting step. It's what recognize is asking us to do is to be able to identify when someone might be triggered or activated. And let me expound on this a little bit. The intent here is not to assume or judge. That's actually the opposite of trauma-informed practice. But if we see behavior in a patient that might signal that they're in this kind of fight or flight mode, that their amygdala is on, they're perceiving some kind of threat to be present. What this is asking us to do is to resist ourselves becoming activated and escalating, and then being able to respond with empathy and compassion and getting people plugged into the help they need. The 4th R is avoiding re-traumatization. If I had more, I can come back to this. I just want to, I'll skip over this for now, but if we have questions on it, I can come back to it. There are 6 really important, I think, guiding principles of trauma-informed care. These include things like maintaining a sense of safety, and we're not just talking about physical safety, but cultural, emotional safety, trustworthiness and transparency. So the idea here is not to assume that a patient should just trust us, but when we go into the encounter, to seek to earn that or build trust between ourselves and the patient and family. Peer support, really important, collaboration and mutuality, empowerment, voice and choice. So really this is about sharing power, allowing people who potentially have had decisions made on their behalf, which is a form of trauma. So sexual abuse, again, someone made a decision on the behalf of a person without their consent to complete that act, for lack of a better phrase. But what empowerment, voice, and choice and these sort of collaboration, peer support constructs do is really help to level the playing field to give people a sense of power over their own lives. And then lastly, having a meaningful understanding of cultural, historical, and gender issues, super important. If we're not informed about these issues, then it's very difficult to be trauma informed. But the nucleus, the sort of central link that sort of brings all these concepts together is this understanding that people can heal out of trauma, and it has to happen through a context of relationships. So I have a couple application points I want to offer in the few minutes that I have left. I'm going to breeze through this next one. If you want to just scan this QR code real quick, this is a free resource that is available online, and it's kind of a self-contained sort of module. I think it's really high yield if you want to kind of understand how, from a physical exam perspective, we can be more trauma informed. What they cover in this module, I've sort of summarized it, is some sort of key ideas like before you even lay a stethoscope on a person, set the stage. This includes things like get eye level, give an overview of what we need to examine, ask permission, especially if we're examining sensitive areas of the body, ask if there are any concerns that we should know about, any cautions that we should have. During the exam, the central theme is you only do what you need to do and you communicate as you go. So instead of just assuming that once you start to look in their ears or their eyes, the rest of the body is fair game, just kind of narrate each part of what you're examining. Some photo examples here. So here, this is less than ideal, although this is a typical positioning for people when they do the lung exam, but the examiner is behind the patient. And so we can still complete get a thorough listening of the lungs, if we move to the side of the patient, where at least the patient can still kind of have the examiner in their peripheral vision. Here, the examiner is doing a thyroid exam from behind the patient, and there's a role for potentially going next to the patient and examining the thyroid as well. And then here, the examiner is trying to check the patient's radial pulse, but her arm, the patient's arm, is pretty close to her groin. So that might not be the best area to check the pulse. And so what you can do is just ask them to extend their arm, place it on their knee, where it's less invasive to check the radial pulse there. Facilitating behavior change should be grounded in a relational context. I'm going to skip over that one for now. I think there is a potential to destigmatize discussions about trauma. And first it says destigmatize, not discuss on every visit. To be clear, the point of this slide is not the trauma. We do not want to have a voyeuristic view into people's lives. We don't want to pry. What we care about is how those experiences of trauma have affected the person, how they continue to contribute to health problems, behavioral issues today. It's amazing to me how much people are willing to, and they want to share if they're in a safe and trusted setting. I've heard it described like a breath of fresh air when a patient feels understood. It's like, okay, now that that's out of the way and you get where I'm coming from, let's change some things because I need help. And studies have shown that the majority of patients really appreciate when their physicians acknowledge the impact of trauma in their lives. Actually, most welcome the conversation. And that's simply also because, listening itself has therapeutic value. So some 3 key reasons why, we could consider talking about trauma. It helps us to align ourselves with the patient, especially when it comes to health risk behaviors. Knowledge is power. There's an intergenerational component of trauma that I did not talk about, but this helps to break those cycles. And then third, it gives us an opportunity to focus on strengths, to be able to say to people, you've overcome a lot of things, and yet here you are. You're still pushing forward. You're not giving up. That's real strength. And the question that I ask very simply, if I feel like, this is potentially a clinically significant issue, is how was growing up for you? Mostly okay or pretty difficult? So in summary, ACEs are associated with many long-term health and behavioral problems. They are a potential cause of toxic stress, which if that occurs during early childhood, 0 to 6 years, can profoundly disrupt brain development. Trauma can show up in the clinic, in the hospital, through hypervigilance, emotional regulation, avoidance, and more. We also have to understand how that affects our performance as well and take care of ourselves. Don't forget, it's not about what's wrong with you, it's about what's happened. We talked about the 4 R's. And then here's some trauma-informed concepts that we can consider as well. So with that, I will pause. I don't know if we have time for questions, Chad, but I'm happy to stick around. And thanks for sticking around. I know I went beyond the noon or the 1 o'clock hour for you guys. Yeah.
Dr. Sonu, are you able to hear me?
Yes, I can hear you.
Okay, so I'm Joe Kowalczyk. I'm chairman of internal medicine, and I've been in practice for 24 years. So when you give this talk, I have a mental picture of those patients who I've taken care of over the years, and certainly they are challenging. I mean, it's when you talk about avoidance and other behaviors, I think about those behaviors in myself also, that, if I look at my clinic schedule and I see that person's name on there, I want to go home. I don't want to.
Ditto. I'm with you.
And the same is true for the hospital setting. I know, after all these years, trust is a big issue. Developing a relationship with this person is a big issue. When they come to trust you, care is much easier for them.
Absolutely.
But a lot of these people, I mean, they are so time-consuming and emotionally taxing on you that they're very difficult to take care of. Many doctors will say, go find a different doctor. I can't help you. That's the easier solution for them, but not doing that patient any favors in the long run.
Right.
And, these patients that I have, they are the drug seekers in the hospital, if you want to label them that way. They're the opioid seekers. They want their benzos. They want their sleeping pills. And when you go into the room, you go in with your boxing gloves on. I mean, that's the way it is. It's like it's hard to go in and you feel like you're the one being beat up. You're part of the fight. And so how do you, what suggestions would you have for the residents? I know you went through kind of some of this stuff, but how would you, before you walk in that room with your boxing gloves on, how do you approach the person that you've labeled a drug seeker and reframe it and say, this is a human being. I need to be empathetic to their situation. And especially if you're taking care of them for a week in the hospital, every day you're going in, it's the same issue. I need more opioids. I need more IV Benadryl. I need my sleeping pills. How do you maintain your humanity when you go in that
Yeah.
room every single?
Yeah, that's a great question. And thank you for sharing that. Yeah. So this is not easy. And none of what we're talking about here is easy. Of course, it's easier said than done in large part. Before I go into any room, I take a moment and I do a 3-second breath, like, and I just say to myself, it's not what's wrong with you, it's what's happened. And that helps me to put into context. It kind of sets my frame for if the encounter doesn't go the way that I was hoping it would go. If the patient and I get off on the wrong foot, instead of sort of taking what they say at face value, I don't want to change that, doc. We're not going to change that today. Instead of receiving that at face value, what's saying to myself, it's not what's wrong with you, but it's what's happened. What that helps me to do is to say, you know what, there might be a reason that they don't want to change the medicine. There might be a reason that they keep asking for this particular drug. There might be a reason that they're afraid to go down on their pain medication, even though we talked about it the last time they were here, right? And so it kind of helps me to maintain a perspective of curiosity and inquiry. And specifically when it comes to trying to facilitate behavior change, one really important piece is that I've found anecdotally greater success when I can demonstrate to a patient that I understand even how that substance even benefits them, as paradoxical as that might sound. Smoking cigarettes, for example. Cigarettes contain nicotine, which is a very powerful, fast-acting anxiolytic, and it helps to de-stress people. It's highly addictive, it's cardiotoxic, and it's packaged in tar, right? So it has these devastating collateral consequences. But the first time when I was talking with a patient and I said, how does smoking actually help you? They were just floored. And actually the encounter was kind of not going great beforehand. But they were floored and they're like, I never thought any doctor would ask that question, but my mother has been sick for the past 18 months and I'm really scared to lose her. And the only way I can control how I feel about this is to smoke a cigarette when it's after dinner or when I wake up in the morning. And so for her, the behavior of smoking cigarettes, even though she knew we wanted her to quit, even though she was well aware of the health consequences, it was related to some other reason that I could understand as a human being. So I don't think the goal, our goal is for, the way I look at trauma-informed care, I don't think the goal is to get people to change in action. That's a hope. But I think our goal is to understand people where people are coming from and be a partner in their sort of journey and progression of making changes in their lives. And so I don't couple myself to the result. I couple myself to being human with people. And that's what I care about most in the encounter. I see a question in the chat. So any thoughts on what is the body's adaptive advantage? Yeah, so this is a great question. So, why is there inflammation when we're stressed? Our stress response systems were designed to save our lives with an acute stressor. So if we're all hunter-gatherers and we came across a saber-toothed tiger, I better have an efficient stress response system to fight. I probably wouldn't fight, or run. That's probably me, or freeze, right? So in the way that our brain sort of evolved was we handle these acute stressors. We have rapid activation of our sympathetic drive. Our pupils dilate, our blood vessels dilate so we can exchange oxygen more efficiently to our muscles. We have these it's a survival mechanism is really what it comes down to. And it becomes problematic when you can't turn that stress response system off, when it's being constitutively, repeatedly activated through these other types of adversity that frankly did not exist when we were hunter-gatherers, living in that era. These problems of community violence, racism, discrimination, intergenerational traumas. Like these are all sort of modern day types of issues that have led to sort of persistent environments of toxic stress that often just go unaddressed for a long period of time.
I think those are all the questions from our live in-person audience. I don't see any other ones popping up on the Zoom chat, but I want to thank you deeply, Dr. Sonu, for this fascinating talk. Also very timely with the environmental trauma that's been going on over the last year to couple years. So thank you so much for opening up our mind and hopefully integrating some of these practices into our everyday clinical practice. Thank you so much.
Yeah, thank you for the invitation. And you know, I'll drop my email here. If anybody has any questions, I'd be happy to take them as well.